Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hello, thanks for joining us for today's webinar, Home Health Final Rule Update, What You Need to Know. My name is Laura Barnett, and I'm on the marketing team at Axxess. Axxess is a leading home healthcare technology company offering a complete suite of easy-to-use, innovative software solutions, empowering home health, home care, and hospice providers to grow their business while making lives better. Joining us today is Charity Farnsworth from HealthCare ConsultLink. Charity is the Senior Vice President of Consulting Services for HealthCare ConsultLink. She oversees field consulting, due diligence, education, and policy and manual content development for HCL for multiple service lines and specialty programs. Prior to joining HCL, her home care background included managing and rebuilding agency operations, clinical project management, and overseeing clinical operations in multi-site scenarios. She also served as a national PDGM trainer in 2019 prior to the payment model change. Presenting with Charity is Mike Carr. Mike is a senior product manager at Axxess. His clinical expertise is critical to the development and training associated with Axxess's home health analytics in our complete suite of solutions. During his time at Axxess, Mike has helped the company further develop OASIS scrubbing, agency analytics, and PDGM-related software enhancements. Prior to working at Axxess, Mike served for more than a decade at Home Health Gold, where he held a variety of roles. Mike's background as a physical therapist was instrumental to the development of many of Home Health Gold's analytics related to functional scoring, therapy thresholds, and episode management. He also has nearly 20 years of experience as a physical therapist for Bangor area visiting nurses in Maine. Before we begin, a few housekeeping items. Your phones have all been muted, although we invite you to submit questions through the chat function. If we have time at the end, we will answer as many of those as we can get to. If we don't get to your question, we will follow up via email with any unanswered questions after the webinar. Slides from today's presentation, along with a recording of the webinar, will be available and will be sent to everyone who registered via email. They will also be posted in Axxess's Help Center. And now, Charity and Mike, over to you.
Thank you very much, Laura, for the introduction, and thank you all for joining us today. As you can tell, we'll be speaking about the final rule changes for 2021, which is fast approaching. We're happy to report, as you probably already know to some degree, that the changes are not nearly as dramatic or drastic as they have been in past years. We have no overhaul to the payment structure or anything that will cause us to totally relearn our business like we've had in the recent past. So the changes are more subtle, but still significant and still certainly need our attention. We'll be covering a variety of topics, including the decision to continue the PDGM behavioral adjustments, the permanence of the emergency period changes that went into place earlier this year, including telehealth changes and the ability for non-physician practitioners to sign plans of care orders and to order home health services, payment rate changes, which is an annual event, happens to be a positive change this year, which is nice to see, changes to wage index, changes around the infusion therapy rules, and probably, or definitely most significantly, we'll be discussing the WRAP timely filing changes that will be coming along in 2021. So that's a little bit of our framework. I'll be speaking about the rules, and Charity will certainly chime in with her organizational expertise to make sure that we have some great takeaways from this session to know not only what the changes are, but what we can do to survive them well and to maximize the agency's ability to move forward in a healthy manner. So first, let's start off with the decision to continue with the behavioral adjustment. As we know, there was much debate and it was kind of a moving target when PDGM came into play a year ago, where CMS had a theory that we were going to behave in a certain way. And because of those presumptions, they decided that they were going to withhold some money, essentially. And that settled down to be a 4.36% behavioral adjustment. CMS was in hopes that, or the NAC and home health agencies were in hopes that that CMS would have enough data at this point to be able to say, gee, you didn't misbehave the way we had thought you might, and you can have that 4.36% back. But unfortunately, NAC and other advocates have not won that battle yet. They're in hopes that there'll be the ability to revisit that sometime in the middle of 2021 and perhaps have it rolled back at that point. But at this point, CMS argues that there's just not enough data available in the PDGM payment system yet to make that determination. Do you have some thoughts, Charity, about how that can come into play and what agencies should do about that?
Sure. So to add what Mike is saying, you know, one of the challenges that we've had this year is that CMS anticipated that, for example, agencies would change their behavior to avoid LUPAs. Well, unfortunately, COVID came along and we've had more LUPAs in some agencies, but it hasn't been because the agency was, you know, doing things a certain way intentionally. It was because of the nature of the pandemic. And so, you know, until we have a rollback on this or a change where potentially NAC, you know, advocates and wins that battle for us, along with other agencies contributing to that, it's just going to be very important for agency owners and administrators to really make sure that we are doing everything in an agency that we need to be compliant, to make sure that we have correct information and that we have complete information. You know, we know from PDGM that, for example, coding plays a very big part in making sure that we get the appropriate reimbursement for the patient for what we need to do for them. And so anything that the agency can do to make sure that their coding is compliant, is correct, is complete, and that we have a good assessment for that patient to make sure that even things like the functional assessment are done properly, that's going to make sure that the patient's condition and the reimbursement that it warrants is correct, which then helps to insulate a little bit against the behavioral adjustment that is going to come off of the payment. So I think in that case, it's really a matter of just looking at agency processes and making sure that the agency is doing what's necessary to try to minimize the impact that that behavioral adjustment will have on that patient's care. So that was it, Mike.
Great, thank you, Charity. And I agree. I think that to build a good case from the home health agency side of things, that we don't deserve to have the behavioral adjustment. We need to behave properly, I think. So, and I think you're right. It really comes down to doing the right thing, coding accurately, and providing the visits that are necessary. So, thank you. The next area that was clarified and finalized or made permanent in the final rule was centered around telehealth. And the next 2 points will be falling in that same category. But the first one is related to telehealth. And this caused a little bit of confusion earlier in the pandemic when things were a little bit chaotic and rules were changing day by day, not even week by week. But the emergency rules enacted have now been made permanent. So what we're used to for the past few months will be set for the foreseeable future, unless something happens to change them. But for now, they'll be made law and be made permanent. But keep in mind that the telehealth changes must be tied to specific patient needs as identified in the comprehensive assessment. And Charity will add some great thoughts on this in a second as well too. But and also the medical record should explain how the telehealth services facilitate the treatment outcomes. So we can't just be doing telehealth visits because they're more convenient and cheaper for the agency. We really need to document that well about how they're going to give us the outcomes that we're looking for. And the technology may not substitute for the in-person visits that are on the plan of care. And lastly, the telehealth cannot be considered a visit for the purposes of eligibility or payment. And I think that was something that some people in the industry had a misconception about, that we were going to be able to do these telehealth touch points and that would be counted as a billable visit. And that's not the case, and will not be the case in my understanding for the foreseeable future, unless there's some dramatic legislative changes. So, Charity, you want to round us out on how they conduct accordingly to this?
Sure. So I think some of the other things that an agency leader would need to look at is making sure that staff really understand how to use telehealth properly. You may not have been using it very much up to this point or minimally, but the fact that the pandemic is continuing and has stretched out longer than I believe anyone hoped means that you need to make sure that your staff understand when it's appropriate to use telehealth and how to do that properly. Even looking at things like which platforms are acceptable to use, is FaceTime okay versus is TikTok okay? You need to make sure that you have a policy in place to cover the use of telecommunications in the agency operations for care delivery, and just educating even the patients. That's one of the things. It's interesting, just this morning I helped an elderly family member do a telehealth visit, and she normally works on a computer just fine, but she really struggles with how a telehealth visit via FaceTime is supposed to work. And I think we can take for granted that patients can adequately use this type of functionality, but we need to make sure that if they need assistance, that we are looking at ways to get that assistance for them to maximize the use of it. The documentation Mike mentioned is also important. We do need to make sure that the medical record explains how that use of telehealth will facilitate the treatment outcomes. But getting back to even the basics of documentation, remember what we all learned in school. If you didn't write it, you didn't do it, which means that staff need to be trained properly on how to document the use of telehealth and make it a part of their normal documentation. So I would make sure that those things are done, and like I said, make sure it's in the plan of care and that you have a policy around it. If you're not sure what that means, you're welcome to reach out and we can help clarify on that. But you do need to make sure that you have one to cover what your staff are doing, because you may be asked for that in the event of a survey. So.
Wonderful, thank you.
Mm-hmm.
And along the same lines, as far as legislative changes that were adopted early pandemic, hopefully we're towards the end of the pandemic, but doesn't really feel like that all the time, were the rules centered around non-physician practitioners, which have been argued for as long as I can remember, that they should be able to certify home health periods of care and order home health services. That those changes are now permanent and accepted as well. So that's wonderful news, and certainly one very nice thing that's come out of the pandemic. I don't think that's a very long list. So, but as we can see here in the slide, they're now considered as allowed practitioners. So they can certify, establish, and periodically review the plan of care, just as physicians and podiatrists and such could have done previously. They also can perform the face-to-face encounter for the patients that they are certifying. And this is, again, not limited just to this public health emergency time period. This is from this point forward. But the caveat is that all organizations should certainly refer to their state practice acts to determine any regional or local limitations there may be on those rules. So good. We'll put this one in the good news category, definitely. So, Charity?
Exactly, Mike. I think a couple of other things I would want to stress is, you need to make sure, for example, even if you're in a state where it is allowed, for example, I live in Texas and it is allowed in Texas, but you want to make sure, for example, if they are providing care for patients that fall under traditional Medicare, that they are PACOS enrolled. They may not need to be for other payers, but if you have, other patients that are in your agency that may not need PACOS enrollment, that's okay. However, for traditional Medicare, even these practitioners have to be PACOS enrolled for you to actually bill for the services that they're managing. So I think to look at details like that is important. And I will say one of the things that has come up that I want to stress is during the pandemic, agencies have had difficulty getting physician orders and now allowed practitioner orders signed. And some of them are still carryovers from earlier in the year where they were already trying to get orders signed, maybe from difficult to access physicians before the pandemic started. And I get the question very frequently, well, can the nurse practitioner sign this order now that they're allowed? You have to make sure that you're paying attention to the date of when this became an allowed practice for them to follow patients versus what you may have that's older that needs to be resolved. Because you want to make sure that you're getting the right person to sign if it's on something like that. So moving forward, it's not going to be a problem, but if we are still having some carryover from situations like that, just make sure that you're paying attention to the dates on that, because otherwise it might turn around and come back and require rework, and everybody has enough work on their plates right now. You don't need to go back and do something a second time again. So.
Yeah, that's a great point, Charity. I don't think I would have thought of that, but it does make sense that we need to be cognizant of who made the order, and someone else can't be signing it. So thank you.
Yes.
Again, another one in the good news category, the payment rate changes. Maybe not so much in the good news category as was anticipated, because the proposed rule had hoped for a 2.6% increase in our standardized rate. And as it turned out, which would have been a $540 million increase across the industry, as it turned out to be a $390 million increase, which comes out to 1.9%. So certainly moving the needle in the right direction. I'm not sure if that keeps up with cost of living and inflation and other expense changes that Charity will speak about, but at least it is a positive move. And what that calculates out to for the national standardized 30-day payment rate is $1,901.12 for the 30-day period. So again, obviously that's going to be moved up or down depending on your HIPS code and your PDGM variables, but that's the starting point for the standardized 30-day payment period.
It is, and of course it's not, like Mike said, it's not a huge difference, but $37 on average is $37, especially when we're talking about trying to maximize every dollar in this business. This is, I think, where the things that we talked about with PDGM in general and the overall shift from the 60-day model to the 30-day payment period model becomes even more important about managing costs. This would be the case even in the absence of a pandemic, but we know that agencies have been hit quite hard this year with extra costs for things like, personal protective equipment. Maybe they've had to invest in additional technology costs that they wouldn't have otherwise to be able to do certain things, whether it's having staff work remotely, buying computers and other technology. So I think managing costs becomes even more important. Even if we have a little bit of a bump in the payment rate, it's still important because supplies and materials like that we use in the everyday practice, they are expensive on a good day, and they can be even more expensive if they're not being monitored, and we just have to make sure that those are being managed. This is where I think overall even episode management from the visit standpoint is important. In a moment we'll show you what the per visit rates are going to be, but every visit that is done costs the agency money for the staff and for the associated costs. And so we want to make sure that you're managing your visits appropriately and doing what's right for the patient, but also making sure that that visits are not getting out of control, because it's great to give the patients what they need, but you also still have to pay for every visit that's made. So you want to make sure that it's an appropriate balance between those two things.
And here are the payment changes that Charity had mentioned, and I couldn't agree more, Charity, with what you said about managing episodes. I think that's really the crux of why some agencies are successful and others aren't as successful, is really being attentive to those details and managing each payment period like its own little cost center. It's own little business by itself. We have X amount of money coming in. We can only have less than that amount of money going out in cost for each of those payment periods, or we're just not going to make ends meet. We're not naive enough to think that's going to happen on every payment period. That's just not the way PPS or PDGM is designed to work. But we can't lose money on every payment period, or we know we won't be in business to be able to take care of the patients that need us. So I think that's a great way to think about it. I certainly won't read you these numbers, but you can see that there's a slight increase for each discipline, and certainly this is in your slide deck that you can print off if you need this for anything. But we can see we have a slight uptick in our reimbursement per discipline from 2020 to 2021. The next topic doesn't affect everyone, and certainly doesn't affect everyone equally, but there is language in the final rule that speaks to the changes in the wage index. And again, that's related to whether you're a rural or non-rural or urban or metropolitan area, and how, if there's a shift in your designation from one category to the other, how those changes are being handled. And Charity can elaborate.
Well, just to add, there's not a whole lot we can add to this except to say you may want to check your area and make sure that your CBSA designation is not changing. There are some counties that are going, for example, from non-rural to rural and vice versa. And the good news on this is that they did put a cap on this decrease, so they are limiting it to the 5%, and they're doing that so that the effects of these CBSA changes are basically phased in over 2 years to try to minimize the impact on an agency that is seeing that type of change. So make sure that you are looking at that for your particular area, because if your county is changing, it may be a positive change for you, or it may actually be a change in the direction you don't really want to go. But at the same time, that would be something that's very specific to your agency. So I would just say take a look at that when you can get to that, and that way you're aware of what it will do for next year for you.
Great, and correct me if I'm wrong, Charity, but they could search for that based on their zip code, correct?
That's correct. Mm-hmm.
Yeah, perfect. Thank you.
Mm-hmm. Okay, so there is a change coming with the infusion therapy as well, and this one, there's a lot of questions about it. We are going to just touch on some of the highlights today, and we're not going to get into extensive detail about it. But we'll go over the basics of it, and then obviously if you have questions, you can reach out afterward, and we'd be happy to answer what questions you do have. The changes in the final rule around infusion therapy for next year apply to home infusion therapy suppliers the way CMS defines them as such. There are specific requirements for these types of providers, and that includes accreditation as an infusion provider. So they're not talking about your accredited home health agency that may be CHAP accredited, for example. They are talking about agencies that have actually gone through the process of applying to be an infusion therapy supplier, and that have been accredited by one of the approved organizations for that specific type of provider. Now, they are paid separately from services paid under the DME benefit, which is one of the questions that we do get. But one of the most important points here is that starting in 2021, a Medicare certified home health organization may not provide infusion-related nursing under the home health episode of care. Some of the things that are changing, for example, is that home infusion therapy suppliers don't need to be Medicare certified to provide those nursing services. Patients don't have to be, they're not going to have to be homebound anymore, because this is not going to fall under the Medicare skilled home health benefit starting in 2021. All of the nursing that's done will be provided under this new home infusion therapy benefit. There is a process that's involved in an agency being able to enroll as a home infusion therapy provider. We're not going to go through the detail of that, but there are some steps in that process. That process could not start for enrollment until after the final rule came out. So if your agency is interested in doing this, there is a process you would have to follow in order to be able to do this starting January 1st. And so you want to make sure, if you want to go this route, that you look for the detail of what that process is, because it's not going to be as simple as just saying, okay, I'm just going to do something different in my everyday practice come January 1. There actually is an enrollment process and paperwork and costs and things like that associated with it. So that's what we're going to talk about today. And again, if you do have questions, you're welcome to reach out and we can go over more detail with you.
Excellent. And then I think in my mind, the most significant change is centered around the WRAP timely filing. So I hope this isn't startling news to anyone that the WRAPs that we had to adjust to this year to being only 20% are now going to be a 0%. So we still will have a WRAP, and but there will be no payment associated with it. But worse than that, is the fact that if that wrap is received late, there'll be a penalty. So we've gone from getting half of our money with our wrap to getting 20% of our money to now, if we are not timely and organized, we'll be losing money. And this will be followed the following year by the removal of the term wrap and moving to the notice of admission. But I think it's important to understand, and Charity can explain better than I can likely, that when they talk about the receipt of the wrap in 5 days, if it winds up being received on day 6, you're not 1 day late, you're 6 days late. And the penalty is a per day penalty. So at that point on day 6, you're 6/30ths of the way into that payment period, the 30-day payment period. So there's a 20% reduction in your payment. So day 7 obviously is worse than day 8 and so on. But it's a little confusion, I think, in some people's minds saying, well, it needs to be there in 5 days. If I get it there in 6 days, I'm a day late, which is only 1/30th, but that's not the way it's calculated. It's going to be that would be 6 days late, and therefore 20%. And Axxess provided a full webinar on this yesterday, provided by, I believe it was Tammy Ross and Sophia Saldivar. So if anyone missed that and needs that, certainly let us know. We can get you a link to that presentation as well. But I'm sure Charity has some great operational thoughts and strategies we need to keep in mind to prevent this from being an issue for our agencies.
Sure. Mike, would you go to the next slide where we actually have an example with dates? I think that might help as I talk through it.
Sure.
So this is the example that actually is in the final rule document that came out, and this was provided by CMS to give you an example of a practical application to plug in some dates and see what the impact would be. So for example, if the start of care date is January 1st of 2021, in order to be considered a timely filing, the wrap has to be filed on or before January 6th. And the way that they lay it out, you can see here on the screen that January 1st is considered day 0. Then you count out 5 days from there, which would get you to January 6th, and that's when day 5 occurs. Now, if this no pay wrap is submitted on or before January 6th, then you're okay as far as being timely filed and there's no penalty. However, if you get to January 7th, then like Mike said, that's where it starts getting expensive. So if you file January 7th and after, you're considered to have been untimely in the filing of that wrap. That's when the penalty starts, and the penalty does go back to day 1 of that 30-day period. This is going to happen for each 30-day period that the patient is on service. Now, one thing that has changed is the requirements in order to file the wrap. In order to file the wrap, you just have to make sure that you have the written or verbal order that sets out the services that are required for that initial visit. You just have to make sure, for one, that you have that received and documented, and you have to make sure that the initial visit for that 30-day period has been made and that the patient is on service if it's the start of care. So there are some changes as far as what has to happen to bill the wrap, because we're not really billing anything. They're not looking, for example, for your comprehensive assessment with your OASIS data and all of that, because they're not giving you any money based off of the data that comes in and establishes the payment. Because this is a no pay wrap, they're just looking for, tell us that the patient is on your services and do it timely, and then you get your payment when everything reconciles at the point of the final claim. In this case, the wrap is being filed to establish the home health period of care in the common working file and to trigger the consolidated billing edits. Those are the main reasons that we are now going to be doing a wrap in the year 2021. Mike referenced that in 2022, that will then change to the notice of admission. That will also bring about a little bit of a change because that's not going to be expected every 30 days. But for 2021, we will be expected to do a wrap for each 30-day period, and these are the expectations and what will happen if it's not done in a timely manner. So what that means for your agency processes is that you have to look at your back office processes for getting the patient on board, getting them confirmed as admitted, and making sure that whoever is doing your billing has what they need in order to submit that RAP in a timely manner. So that I would recommend that you take a look at what your processes are, because if you find right now that there are some gaps, you have 6 weeks to get that corrected before we roll into the new year and this becomes the process. The other part of it is you want to make sure that as everyone's finishing their budgets for 2021, when you look at the cash flow part, if you haven't already been factoring it in for 2021, you now have to factor in that you will not be getting that 20% up front. You have to wait for the final claim in order to get that reimbursement. And so those are some of the things that I think you should take into account. One of the other things to take into account from a cash flow perspective that is not as directly tied to this, but that does play into it, is if you're having trouble getting your final claims billed in a timely manner for whatever reason, you're going to have more of your money tied up in the final claim now because it's 100% of your payment. So whatever's holding up your final claims being billed, try to solve that problem as much as possible, or decide how you're going to address it in the next 6 weeks, because you now don't have any upfront cash flow coming in effective January 1st of 2021. So you will have to make sure that you can manage your business until your final claim comes in. And the longer it takes to do that, the longer you have to wait on that cash flow. So again, this will give you an example of how to file it timely and make sure the dates work. Then you just have to look at your agency processes and ask the question, are we doing what we need to do to make that happen so that you don't run into any problems with it? So there is an MLN Matters that was put out by CMS that talks specifically about this and goes into some of the billing details itself. That's MM11855 that was put out in October. If you need that number again, you're welcome to reach out and we can provide that to you. But again, that MLN Matters starts to go into more of the actual billing part of that process. And if you do have any questions, that might answer it for you. And again, you're welcome to reach out to Axxess or HealthCare ConsultLink, and we would be happy to help with those questions also.
Thank you, Charity. Thank you, Mike, both for sharing your expertise and your wisdom with us. Please remember, we are going to email everyone who registered a link to the slides. We're also going to post a video recording of the webinar on our YouTube channel, as well as in the Axxess Help Center. If you've not checked out the Axxess user community, I strongly encourage you to visit us at community.axxess.com. It is a great place to share information, to ask questions, and to connect with other Axxess users. I want to thank Charity and Mike for their time today, and I want to thank you so much, the listener, for sharing your time today with us and helping us deliver on our mission to empower healthcare professionals with leading technology solutions. Have a fantastic day.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.